So we talked about doing the excisional biopsy first, and that's mainly just to give us something to work on. Normally with a excisional biopsy, you identify the lesion you want to remove, and then you clean it 3 times, as discussed in the sterilization section. And then if you have a skin marker, you can actually mark out the section that you want. Of course, you want it to be whatever the width of your, so it needs to be 3 times longer than it is wide. And then once you figure it out, you can just eyeball your excision. If you don't have any skin ink, just kind of try to make it symmetrical on both sides so it comes together real nice. Now, I'm just pretending there's something right here, and I'm going to start, and I want to do one full line to one side, and then start on the other side and do one full line to the other one. You don't want to do like a sawing motion, and it's better if you use this part of the blade right here, because that works the best for getting a nice fine line. And again, I want my angle so that it's pointing inward this way and inward that way, so I'm getting that nice concave direction, so that way when it comes back together it pulls together real nice. Okay, so of course this is all numbed up already. Okay, make that a little better. And then when you're undercutting it, again, you start on one side and then you go to the other side and go that way. Again, the reason why you do that is so that you don't end up making an accident and cut into this side of the laceration. Okay, so once you, and then this would go into the solution to be sent to pathologist. And then you want to do a little bit of underscoring to make it so that you can pull it closer. Usually they'll use iris scissors to do this part, but we don't have iris scissors. So just be really careful with underlying anatomy. Okay, then you have something you can sew together. Okay. Okay, so we're gonna draw up medication for a digital block. Here we have 18 gauge, which we usually use to draw up our medications, and we usually inject with a 22 gauge. You could go with a 25 gauge too, or something smaller if you like being nice. I'm against it.
You're against what?
Being nice.
Oh.
So typically speaking, you can use a 1% or 2% for a digital block. You definitely don't want to use any of the epinephrine stuff when you're working with digits. If it's going to be a long procedure, you can throw in a little bupivacaine or marcaine if you like. Just make sure you keep in mind that bupivacaine has a absolute contraindication with pregnant women, so keep that in mind if you decide to use that. Today, since we're just doing a practice injection, we're just going to use the 2% lidocaine, so that way my finger is not numb all day. Yeah. Mm-hmm.
How much do you want? How much do I want?
I'd get a full 5 and do. You'll probably want to do about 2.5 on each side of my finger.
Huh?
Usually do about 2.5 on each side of the finger. Both webbing spaces with alcohol. Some people choose to use betadine, but alcohol is sufficient. So I put a big bleb there at the web, and now he's going up towards the top of my finger. He's going to inject while he's pulling out. That feels awesome. Okay.
in the mail.
Oh, I'm just having a great time.
You're having the best day ever?
Again, you want to do most of your injection while you're pulling out. Yeehaw! Just a little numb up to here. So that'll be pretty good. Most of the time, you don't have to inject more than that. That'll usually take pretty good care of it. So that's how you do a digital block. Now, if you do the thumb, you got to get the inside of the web, and you have to do kind of a field block clear down here. You can review your anatomy, because the nerve for this side actually bifurcates here and goes this way. So you can hit both of those puppies if you kind of come down low. And I just kind of go up here and shoot a big bleb, and then without pulling all the way out, I come back and then I go up this way and shoot. And you just kind of block the entire area, and that hits that nerve that numbs up the thumb. So that's it, digital block. So palming is a technique of how we properly handle the utensils. We don't want to put our fingers in the loops, because that slows down our activity, picking up, setting down. It also limits your range of motion, and you can get better dexterity with your suture and your laceration repair if you do what's called palming. Now, it takes a little bit of practice, but eventually it becomes second nature that you can open and close the driver without ever having once needing to put your fingers into those loops. That act of opening and closing the driver takes a little bit of practice, but with some time, if you keep doing it, despite how frustrating it is at first, you will get it down and you'll become a better suture provider. Okay, so because there's literally there's sutures that I will be doing like this, and I can't do that if my fingers are in the loops. So you just got to get that and get it down and get used to it. So now we're going to show it to William here and have him practice opening and closing the driver without.
As a lefty, it's a little harder, but
Oh, you're a lefty.
yeah.
That's even more difficult.
But
So they do make left-handed drivers. You may, at some point in the future, you may want to order some and have your own. You just have to learn how to get them clean, centrifuge, all that sort of thing. Well, you did pretty good with that right hand. Okay, so that's that. These knots, and I'm using old Boy Scout techniques. Rope. When we're tying our instrument tie, all we're doing is tying a bunch of square knots. So square knots. In a square knot, you're just taking right over left, left over right, and it creates a knot called square knot. Very secure knot. Okay. This is all we're doing when we're doing the instrument tie, is making a square knot. So when you're doing your loops over and over again, essentially all you're doing is redoing more and more square knots. If you only do one throw, like when you start your first 2 loops with one throw, you've got no knot, right? So you do another throw, that's one knot. If you do another throw, that's not another knot, that's just half of a knot. You have to complete another throw to get your square knot. Now I just did a granny knot, okay, because I did not go this way, this way. I went this way and then this way, okay? That's not a good knot, and you can see that the pattern is disturbed in here. So you got to make sure when you're doing your knots, you go back and forth, did it again. Here we go. So you got to do one throw this way, one throw that way, one knot. If you do one throw this way, one throw that way, and then one throw this way, that's only 1.5 knots, okay? So you got to make sure you do them in pairs. 2 throws each direction is 1 knot. So if you want to make 3 knots, you got to do 6 times back and forth. Okay, so that's 1 knot. So that's one this way, one this way. That's 2 knots. Okay. All just a bunch of square knots. Okay, so make sure you do one each direction and consider that 1 knot, and I recommend you do at least 3 knots per throw. So on these needles, I like to point out where you attach your driver. Right here at the top, you'll see where the thread goes into the needle. You don't want to attach there because you'll break it off if you're clamping onto that. And then also right about here, you see what I call the J point, which is a lot like on EKGs where you start seeing the little swoop go. So you want to be between that thread and that J point, which I call the sweet spot. You want to get it as close to the tip of your driver as possible, so that way you don't have a bunch of instrument. All the time I see people trying to sew like this, and it drives me crazy because all this is in your way. And you can do it on this way, or you can do it this way depending on which direction you're going. For this example, we're going to do the instrument tie going towards me. So you take your pickups and you manipulate the material, or the skin hopefully, with your pickups and not your needle. If you're manipulating the material with your needle like this, you're going to bend your needle. So you want to pick this up, get it 9 degrees, pull it through, okay? And it's best to go halfway through your wound and then go the rest of the way, so that way you don't end up bending your needle. Again, I want my, what did I do? I want to try to make my sides as symmetrical as possible. You can pull this all the way through if you like. We're doing simple interrupteds in this case, so I'm going to get all the way down there as much as possible. So to start of the instrument tie, you do 2 loops around your driver, and if you're still got a lot of stuff hanging out here, then you can kind of pull it closer so you don't waste material. Then you grab onto it and you pull it towards you. Do another loop, pull it away from you. Another loop, pull it towards you. That's 1 knot. That's 2 knots. That's 3 knots. Do at least 3 knots for every throw, and then trim it up with about 1/4 of an inch on the end, and that's it.
Okay, so for running a series of simple interrupteds, you're going to want all the knots to be on the same side. So generally, consistently, you're going to go in the same direction every time. So if you're having to switch back and forth, it takes a little more stop and think. But to make Jim happy, so you're going to come in at a 40 or at a 90, in, come to the bottom of your laceration. And in this case, because I can't do a complete throw through that way, back up and out, and hopefully I've got enough thread left for this, y'all. If not, you're going to find out what happens when you don't have enough thread. Free advice: if you're working with short thread, take your curved, clip your end, that way you don't pull all the way through, because I've done that on more than one occasion, and then the patient gets upset. Oh, guess what? I have a curved. So
we call that a snap, in case you want to know. You put a snap at the end, so that way you don't pull it through. So if you hear the word "hand me a snap" in a surgical suite, you'll know what they're asking for.
oh, okay. And come. Whoa. Where is the end of my needle? There it is. There we are. All right, it's a little longer than I like, but it'll work for demonstration purposes. So if you have gone long like this and you're really worried about your appearance, pull through, try again. But today, again, we're more interested in tying the knot. So 2 away. 1 towards. 1 away. Oh, where'd my end go? And then 1 towards. Because again, I'm weird. And y'all, color of your thread matters. Dark hair, this blue color, you're gonna have a difficulty seeing it. Find the orange if we've got it. Definitely don't use black on black hair. You'll spend the next 3 hours trying to find the end of your thread every time.
The only thing after you bottom inside, yeah, and okay, so doing a running suture, you start with a simple interrupted.
I should just go into the edge on the same side.
Nope. You go right where you left off with your knot. So you hit right here, and you go to this side underneath the tissues. So your oblique throws are underneath the skin. And the only thing I want to change with that one is you want to try to get it straight across.
Straight across.
You got a little bit of oblique
Okay.
on that one.
Should I pull back and try again, or
Nope.
just do this next one?
This is just practice.
Okay.
Better. It's actually perfect. You got it symmetrical on both sides. Looks great. So make that your last one.
Okay.
And that loop that you have up there right now will end up being your loop that you tie onto.
Okay.
And you want to grab, just like on your regular knot, you want to do 2 loops.
Okay.
stuff.
Mm-hmm. Can I pull through with this?
Mm-hmm. Maybe.
No. So, okay, then what?
It's at this point that you're wishing you didn't waste,
All that thread, yeah.
what is that, 2 inches right there?
Close to 3, yeah. So, yeah. So I should leave slack in this one?
Mm-hmm.
Okay.
Yep.
And then do I loop that, or do I?
You grab onto the whole thing.
Okay.
Good. And when I was doing ortho, I worked with this PA who liked to see how close,
Oh no.
how close to the end of the suture he could use up. Like it was part of his challenge to. Grabbing the wrong one.
Oh.
You need to grab that loop that you already had.
Okay.
Good. That little tag you have left over is what you grab onto.
Okay. If it doesn't undo itself.
So when I'm doing a horizontal mattress, like if I was actually repairing this, like say on a knuckle or something, I would visualize my center and go for my center. If it's something you're doing multiple horizontal mattresses on, that's not as big an issue. But if you're starting your lesion off with horizontal mattress, I picture my center and then I go off to the side to start my repair. The amount that I go off the side is usually about the usual length I put in between my sutures. Okay, now I'm going to go back. Again, I have my visualized center and I'm going to go off to the side just as much as I went off on this side. Thinking symmetry, I want to get my same length on both sides. Okay, and then you want to pull your line through like this. Get this side pulled all the way through first and then the other side. Okay, what you don't want to do is something I see in videos all the time. It drives me crazy. Is, let me get this back to show you my point here. You don't want to do this. I don't want you to see it pulling all the way through. See the torque it's giving that side? It's damaging that skin over there. And if you're working on really friable skin, it'll rip through. So please don't do that. Just do the halfway, pull it through on this side first, and then the other side. If you fear that you may pull that through, you're welcome to use what we call a snap. You take your hemostats, clip it on the very end of your line, and then it won't pull through on accident. So if you're ever in assisting a surgery or whatever and they ask for a snap, they're usually asking for a bent hemostat that they can clip on a line so they don't lose it throughout the operation. Okay. I probably use a bent hemostat for that than for any other reason. Okay, so once you get that all the way through, then you do your double knot, pull it closed. Okay, and you go back the other way. Okay. Usually you get this nice little pucker. Pig skin's a little weird, but, and again, just like normal knot, you know, you do one this direction, then you do one the opposite direction. That's one knot. That's 1.5 knots. That's 2 knots. I usually like to go 2-3 knots. I like the third knot because you can put a lot more pressure on it without causing additional stress to come down here. and it really kind of tightens up that knot so it's not just going to unravel. The horizontal mattress suture is really good for high stress situations. It's also good for, it doesn't leave a lot of scars, you don't get any cross hatching, and it's extra durable for like if you're working on a flexure or near a knee or somewhere where you're afraid the suture might pop open. This gives you 2 different suture anchors for 1 moment arm of stress across the center of that. So it's a much stronger suture than just a simple interrupted.
So do I need to use this drape over that?
Mm-hmm. I'd do it the other way.
Up and down?
Yeah. Do it long way, yeah. And grab your bent hemostat and tack that paper on to the other paper.
Tack the paper onto the other paper.
Yeah, you just kind of clip it so it doesn't fall off.
This paper?
Oh. Take that clip and clip this paper to the yeah.
May not be enough, but
Might be okay.
I don't even need these, right?
Not unless you want to use them somewhere.
Particularly.
I've never really used them much. So shaky.
Alright, so I'm gonna start. Can you feel me if I touch?
No.
Okay, sounds good. So go in, over, and then back through and tie it.
Mm-hmm.
Okay, so right about there. You okay?
Yeah. As a foot celebrity, obviously.
As a foot celebrity?
Yeah.
So I go ahead and tie one or just go back through?
That's right.
This doesn't help when you videotape, right? You feel the same way, don't you?
Well, you know, it's only gonna go 2 ways.
That felt a great way. Is that broken right there? Yeah, I want to avoid that. Go back over one more. A little bit more. It's tough. I'm not seeing it come through.
Just the gloves.
Well, don't judge my gloving, okay?
They're just at a high angle. Good.
Is this bottom? If I accidentally elbow you, please don't take offense, Jim.
As long as it knocks $5 off the bill, would be good.
It really takes a lot to offend me.
Yeah, so physical assault isn't one of them.
No, it's an accident.
All right, how do you feel about?
Looks perfect. Trim it up.
Okay.
So she used kind of a fancy suture down here that I taught her.
Fantasy?
Fancy.
It can be a fantasy. You can
Oh
do
my
whatever you want.
Fancy.
It can
Oh
do
boy.
whatever you want. We'll just keep it PG until you leave. Sound good?
There it doesn't. Just because we recorded.
It'll do a lot better keeping it together than simple interrupteds, which is what most people have used.
That's what I wanted to use. I'm better at it. All right, let me get some. I'm just gonna rinse it off just a little bit, okay? So you don't walk out of here looking like, I don't know, it's the Lord for Halloween.
No, yeah, well, true.
What do you think, Jim, on the foot, like 10, 14 days or longer?
Yeah, I do 14. 10 is usually adequate most of the body, but since it's not a highly used place, it'll probably take it a little longer to heal.
You're gonna need to watch for some signs of infection, so you need to be looking at it at least twice a day, okay? Increased redness, swelling, any drainage from it that's yellow, green, white, and sick, we wanna see you back for, okay?
Alright.
Questions?
What about work?
Oh, what do you do for work?
Frito day. I deliver chips on my vehicle.
Okay, well, your next stop can be here, and then, I'm just kidding, bad joke.
No,
You're on your feet
a lot.
a lot.
No, I don't know, like, if they'll have, I can.
Loop mattress. So it's pretty simple. You just start like you're doing a horizontal mattress. So that's kind of like the horizontal mattress right there, but instead of stopping there, we go back one more time to the other side. Okay, so that makes my other loop. So this is my leading strand, this is my tailing strand, and here are two loops. For your leading strand, you just reach under that loop, grab your leading strand, pull it through. For your tailing strand, you reach under that loop, grab it, pull it through there, and you tighten it all together and tie a knot. There's a lot of stuff there. I'm gonna trim it up and make it easier. It's half a knot. Oops, missed it. 1 knot. Half a knot. 2 knots. Half a knot. 3 knots. Double loop mattress done.
Push the tempo, push the tempo.
What's up with this needle?
It doesn't like to play.
Just keeps rotating in the other direction. Alright. Come on.
So what's real fun is when this kind of stuff is going on while you're working on a real person. You have to keep all that frustration inside. You know, start saying like, "Oh shit."
It's gonna go real well.
Yeah, the patient starts tripping.
Alright, there we go.
Good. You can trim off that little end a little bit. That way it stays buried pretty good.
See if I nicked that. Okay.
So this sutures where I like to comment that there's no way you could do what you were just doing if your fingers were in those holes. I mean, it seriously makes your sewing capabilities much more dynamic.
So this finishing knot. Where it's at.
I just kind of go on the very edge, somewhere a little deeper, so that way it puts the knot kind of deep in the end.
Within the wound, right?
Yeah.
Okay.
Which you sealed up so tight, you're having a hard time getting into. Which is good. Keep the loop.
And don't pull all the way through.
You're just pulling it through, pulling the slack of your current loop closed. Yep. Pull it all the way down. All the way, you gotta pull all. There you go. Now you reach back through and grab it again. Do the same thing. Good. Do it again. I believe this knot is called the Aberdeen knot. And just like all knots and laceration repair systems, they've done lots of research on this, and you'll find recommendations of doing this 8 times, but there's been research showing 3 to 4 times is adequate. So pull that nice and tight. Good. Now just pull your leading line through the loop all the way through. Pull it down tight. Perfect. Now that's your knot. Now you can bury your suture by going back into the wound right by where your knot is. Kind of go deep. Just come out superficially from somewhere on the skin line. And just pull that all the way through and then trim that off. And that, my friend, is a perfectly done subcuticular suture. And I would just reinforce that with 30 strips and be done. It's done. It's done with me. Okay, so I got that knot in there. Next, I want to start doing the subcuticular suture, which is simply this skin I got is paper thin, so I'm currently sewing a very old person together. You want to start really close to the edge. And little bites. There's literally not a lot of skin for me to sew here. Okay, then I want to go straight across. To the other side. Do another subcuticular. Pull it through. Okay, and then I just keep doing that back and forth. After the first couple small bites, you can take just normal bites. I get it lined up exactly across from where I went, so that the actual laceration or suture that's holding it together is going perpendicular to the wound. This bit of place that I'm sewing on this pig isn't like a really great example, because it's not gonna, got a lot of play in it. Now, one thing you want to try not to do is what we call being proud, which I'm trying to show an obnoxious example of. I've gone all the way through, and so the suture will rest on the outside of the lesion. You don't want to do that. So try to be careful to just say subcuticular sutures, so it doesn't go proud into the external. Getting closer here to the end, I want to start taking a little bit smaller bites, so I can fit a few more in there. Okay, so that's all sealed up. Now I want to make one more, dive through there and give myself a loop. These are really cheap utensils, so getting 2-3 clicks is helpful, so it's not turning on you. I get kind of a deeper bite because I'm about to finish my knot. Okay, so now what I do is I get closer down here and I do it from the single so you can see better. I got my loop. I put my 2 fingers through that loop. I grab my leading suture and I pull that down. Okay. And I do that again. Okay. So essentially I'm tying this off using kind of a slip knot. Do that several times. Make sure that my suture looks good. Okay, and then you take your leading needle, go through the loop, pull it all the way down. You can now have a knot in there. And then finish this off. Just go right back where you ended. Wow, this thing is still moving with 3 clicks. And come up through the skin somewhere. Now you have complete buried suture. Just cut that off somewhere. Okay, so pigskin's not working very well. In this case, with a little bit of laxity, which is more a symptom of pigskin than not, I would take some benzoin. I usually do this anyway. I mean, the benzoin is glue. Now this stuff doesn't work on pigskin at all like it does on human skin. I think it's just too oily or something. I don't know what the problem is. But normally on human skin, I like, especially when I'm dealing with facial stuff, you can kind of reinforce it with some steri strips, keep it solid. Most of the time I only use about half of the length. Keep it sterile so I can use the other half if I want to. Yes, this stuff just doesn't get sticky. Cool thing about if you do the steri strips like this is it also acts like a bandage, so you don't really have to put anything over the top of it. I mean, you can just to dress it up a little bit, but this is actually working better than I've ever had steri strips work on pig before. There you go. 3 days, that'll be healed. These will just kind of start coming off naturally over time, and they'll have a beautifully healed wound with no scar whatsoever. It's almost completely invisible. Okay, so that's the buried subcuticular. I don't know if there's enough stuff in there to pop it.
Yeah, I don't know. Yeah. I don't think there is either. Because I felt like I've tried to break up the sack that was in there as much as possible. And anytime I did excise it, like try to get as much out as possible.
So I would just cut from where you injected to where you injected, and just through the first dermis and not go too deep. So we don't need to go very deep. Double check, make sure he's numb.
Oh, no.
I'm like, there's no way you couldn't be numb.
Oh, there. You feel any of this?
Oh my god. No, I'm fine. I'm just kidding.
Of course you would do that to me, right? Between the two of you, it's gonna be a day. That's awesome. Okay. All right. So from here, you think, Jim, from like here to here?
Yep.
Okay. All right. You ready?
Yeah.
All right.
Do you want some pickups?
Yeah, but you know what else I need? This, in case I need to go around it to kind of get the sack detached from the sides of the.
Perfect.
Yeah, and then this. So these are the two things I want out. All right, you ready?
Yep.
All right.
Born ready.
You're born ready. I don't know if I'm going deep enough.
You need to use the round part of the knife. There you go. Good.
Right-handed. To go in just a little bit deeper, Jim. You think I need to go in deeper? Because I really can't see much into there.
All right, now that you are a subcuticular expert, the flap repair is really nothing more than a mattress with a subcuticular flare to it. So here you have this flap lesion. We get lots of flaps. And the problem with flap lesion is, and I see it repaired incorrectly all the time. They do simple interrupteds here, they do simple interrupteds here. Flap isn't really well appreciated or approximated in the middle, and or it's over penetrated with a bunch of sutures in there, and it just isn't done right. And clearly they were unfortunately never told the correct way to do a flap repair. So just like in the flap repair mattress, we're going to start kind of out here, and we want to start out here and end out here far enough away from the flap that our knot suture doesn't overlap our flap. So I kind of go out far, and then I kind of want to come and I want to grab a little bit of that subcuticular skin right there. Then I'm going to do a subcuticular suture that goes directly from where my suture comes out, and then I want to do that same length over here. So basically I just need just a tiny little sub-Q grab of the flap right there, and then I need to go subcuticular right next to it. Okay, and then I want to go wide, so that my ending spot is out here far enough that it's not going to overlap that one. Now, please don't do this. Okay, you're going to rip that flap if you do this. If you have a bunch of this extra stuff that you need to pull through and you're working with real human skin, you pull that all the way through like that, the tension is going to rip that flap. Okay, so what I recommend you do is carefully, very carefully. You can see how friable this is right underneath here. I've barely got any skin at all, so I want to kind of pull that halfway through, and then I can pull that through. Make sure I've got that flap in there perfectly, and then tie the knot out here. You don't want to over tighten it so it all bunches up there. Okay, careful on the strength of your tightening. Boom, you got your flap repair. Then you can just do, you can do mattress sutures if you want to. You can do simple interrupteds, whatever you want after that, because once you start with that flap, you get that flap perfectly nailed there in the corner. Perfect repair there. All right, so we got this hot sock suture guy here who is doing a flap repair. However, this is just a bit more than a flap repair. As you'll notice, he kind of has a star lesion. So he's got 1, 2, 3 flaps to repair. I'm so happy we get more people unloading stuff in our background conversation here.
It's subcuticular on that one as well.
All of them. I just grab one at a time. Don't get too ambitious.
Trying to get it out. And back out.
Yep. So I would come over to this side to end it, so that way you have. No. You need to start in there,
Mm-hmm.
but come out over here. You still, yeah, you still need to go in subcuticular. Then you need to end kind of out there by where you started, so that way you can perfect. So when you pull that tight, all of the various flaps are tucked away in there perfectly. There's literally no other way you would be able to repair something that's that shattered. So sometimes you can get kind of creative with your repairs using that kind of subcuticular slash mattress combo. So you would have got an A for that one, except for one thing.
Okay. Not?
Your fingers were in the loops.
Ah. Oh.
All around me are familiar.
This example is not using dissolvable, but we can use our imagination. And so when you have like really deep lacerations, you want to, or like stuff that's like really far apart from each other, and you need to approximate the deep tissues first. You don't want to sew it together like normal. Like you want to normally be like, okay, we'll do this. No, what you want to do is start deep first and come superficial. Okay, so that your knot is buried deeply. So you start deep, come superficial, and then you reverse it. Okay, I'm superficial now, so I'm going to go back superficial, but I'm going to go back down to deep, so that it's all the knots down deep. It's very important that you notice that here's my suture, and my beginning end and my trailing end are both coming out the same side. The reason that's important is because when I tie my knot, that makes my knot deep to that suture. If I did not do that and I had my trailing end coming out the other side, I hope you can recognize that if I tied my knot now, my knot's going to be over the top of that suture and will not be deep. So it's important that you have both the trailing and leading end of your suture on the same side. And then if I tie my knot there, it's going to be deep. And then you get that nice deep approximation. This is the same concept we use when we're doing mucosal tongue and lip repair, only you start much more superficially. Like if this is a lip, I want my first one to be right here. I mean, lip repairs usually aren't that deep, but you're using the same kind of concept. So starting deep, come out superficial, hopefully not right through the skin like I just did. Back out just a little bit. There we go. Okay, so it's not proud through the skin itself, but really close to the skin, so I get a really nice, pretty finish of the approximation and then I want to go again right across from it. Start really close superficially, and then go deep. Didn't get much. Let's try it again. I'll go really deep. Okay, so then when I tie that, and it's on a lip, I get a buried knot, so there's nothing for them to play with, and it gives you a really nice superficial repair, subcuticular, so you don't have any cross hatching, and it's dissolvable material, so you don't have to take it out. Well, it's really great. It's a great lip repair, and you don't have to worry about them picking it apart with their tongue or food. But one thing I always like to mention, make sure you tell your patients to please do not go out and eat hamburgers or tacos after. A good 3 to 5 days of liquid foods is probably appropriate, so they don't rip these sutures open and end up with a big ugly scar. And deep. Remember to manipulate your tissue with your pickups, not your needle. And you go back deep, back to wide. Good. Okay, so that gets your deep approximation. So now we go back, we go near, superficial. Back to superficial, near. Same line, same perpendicular line to the injury. Tie your knot and you're done. Okay, so with one simple suture, you get your deep and your superficial, and it's stronger than just any kind of simple uninterrupted as well. That would look better on rough skin.
I would hope.
All right.